Okay, to start the case of opening government, I call upon Prime Minister. Here.
Chuck, am I audible?
Yep, loud and clear.
Okay. Right. Setting up my timer. For POI, just drop it on the chat box. I'm gonna accept one from closing if I have time. Um, Starting in three, two, one. First, let's just contextualize what is the significant difference of transdiagnostic and categorical. We're talking about transdiagnostic method. It looks like you try to find the core patterns or process of these are the things that we're going to try to heal. It looks like, for example, if you have an anger issue, regardless of what are the manifestation of this anger issue, whether you're going to be depressive, you're going to be having anxiety disorder, we don't really care. But we try to solve the anger issue first by giving you direct programs like relaxation therapy and whatsoever. But we're talking about categorical method. You're going to divide it into categorical diagnosis. For example, people might have different symptoms when they have anxiety disorder, but they will be put into the same box of anxiety disorder and they will be treated based on this. Those are the key differences of those two methods that we're going to talk about in this debate. But secondly, how does the widespread significantly look like on Earth of the House? Number one, we're going to define a world where professionals are trained to deal with patients with transdiagnostic methods, where they will do not really care about what are the implications, like whether they have what disorder do they have as a byproduct of these symptoms or of these patterns, but we're going to focus on solving the patterns first, solving the processes first. But secondly, it also manifests into manuals like the DSM or ICD that exists in status quo is going to be more transdiagnosis centric in comparison to categorical centric. We want categorical not to be the common practice in the psychological world from the get-go. I think it's a setup that every single team needs to abide in this debate. I'm gonna open room for clarification if there's any going once, twice, three times. Okay, two main contributions come from open government. We're gonna talk about how it gives better treatment for the patient, but second is during the perception of mental health issue in and of itself. The first argument is going to be debate winning because ultimately the purpose of like a mental health debate is to ensure that people can have a better mechanism to heal their diseases or heal their mental health issues. Exactly because like yes, this motion specifically talk about mental health treatment. So whether people are going to be able to heal better or like whether it's going to be more accessible or not becomes the key argument that should be weighed the most in this debate. How do we create better treatment? The context is that mental health issue is very, very complex. I think most disorders actually share common underlying processes. For example, the common processes that people used to have are like avoidance or like anger issue and whatsoever. However, when they face different trigger, it manifests into different disorders or different categories. For example, if someone who own avoidant issue but it combined with loneliness and feeling of constant failure, it will manifest to depression disorder. Or if it's combined with feeling of uncertainty, it manifests into anxiety disorder and many other different cases. It means that some categories might likely have similar kind of processes or similar patterns underlying behind it. So we argue to you that the best way to solve this problem is not to box it into different categories, but trying to solve the core problem in and of itself. Trying to solve the anger issue first. So when you get any trigger, like for example, when you become lonely or when you face uncertainty, it will no longer manifest to depression. It will no longer manifest to anxiety, exactly because you no longer have the anger issue from the get-go. So our mechanization actually solves the problem from the root cause, and it prevents the further issues like further output like disorders and whatsoever. But the problem in status quo is that it's kind of individual who are triggered with multiple issues might have depression and anxiety, but they will go through two different kind of medication, which I think is very very common in status quo because the trigger to your emotion is not one dimensional right now. You can face how someone can feel very very stressed out with the living condition right now, but it can also equally feel lonely because like the world is very very competitive right now with all the pressure and everything. It's most likely than not people have more than one disorder that are caused by one pattern or by one process. For these individuals who are majority in status quo, you need to go through two three different healing system or like two to three different method of healing, exactly because the method or like the the books actually all the treatment medication system makes them to go through all of those things. First, it's going to be very, very time consuming for you to solve all of this thing, but second, it's also going to cause you even more pressure because the amount of treatment you're going to face, like you need 3 to 4 therapy sessions instead of one session or a set because you're just trying to solve the core issue. But thirdly is the significant amount of money that you need to chip in exactly because there are 2 or 3 different processes that you need to get through as an individual. So the output on our side of the house is that we're going to be able to solve the issue with cheaper price, with a more accessible manner to most individuals. I'm gonna take the POI from Kuzen.
So do you think that the current treatment is failing because psychological assessment and interview do not assess the root cause in the status quo?
They do assess all of those things, but they categorize it. They don't care about the process or the pattern, but they care about putting it in a box and making them pay more for treatments that doesn't correlate with each other, that doesn't really solve the core issue in the status quo. I think that's the biggest issue that we're currently facing. The implication to the industry looks like how there's going to be better specialization, for example. Like you have individuals who are trained specifically to solve like the issue of avoidance, to solve the issue of anger and etc. The processes, the R&D is going to be far more targeted. Therefore, it creates an impact, like a betterment of the manuals and whatever. You're more likely to occur instead of talking about categories because it's very, very complex. Because trigger might be different, and it's extremely hard for you to study all of those things because in order for you to heal, for example, a depression disorder, you have to understand of the patterns of the process, which makes the learning process become significantly harder in the rest of the house, makes specialization a lot harder, which also means that practitioners are going to be extremely expensive. So I don't think this is a benefit that they want to co-opt on the rest of the house. So the importance of this argument is that we pose it to you a better healing mechanism for most individuals on the ground. But second argument is regarding perception. The issue we have current status quo is that there is a huge stigmatization or labeling, especially when you when you have diagnosed into boxes like you have bipolar disorder, for example, you have anxiety disorder, whatsoever. This kind of term sounds very, very clinical, sounds very, very heavy to you as an individual. What are the implications of this? The implication is that people feel like they are beyond saving. Like this individual, they feel like they have an issue that are very, very severe, that are very hard to be healed and whatsoever. So I think that in the long run, people this also manifests into people having less incentive to go to clinics and whatsoever because they feel like they are afraid to be judged by other individual because the stigma that are being imposed to them are very, very heavy, like this having certain disorder and whatsoever. The comparative on our side of the house is that the stigma that are attached to you are going to be simply smaller. How does it look like? Because the discussion on Twitter or in any discourses places do not no longer talk about what disorder you have, but what pattern or what process you actually have as an individual. I think it's a far lighter burden as an individual to feel. So they will not feel that they are that wrong as an individual. They don't feel that they are that burdensome as an individual because the burden that people put on them are not as heavy as having all of those disorders. Based on those reasons, probably.
As I promised for that speech, to start the case of opening opposition, call upon LO. Here.
Hello, am I audible?
Yep, can hear.
Okay, POI preference, unmute, raise hand, chat will be fine. Pronouns he, him. I'll start my speech in 3, 2, and 1. Giga, don't kill me for this speech. What OG misses is that those boxes they talk about were not arbitrary. They were made with a very careful selection and assessment of the symptoms and when they come bundled together and the root causes that cause those symptoms. I think they severely undercredit the amount of effort that the scientific and mental health community has put into categorizing people into these neat boxes. And the reason they have done so is that those boxes facilitate the process of diagnosis and treatment in a way that doesn't work under government, when they focus only on the sole symptoms that appear on the surface, and that's why we oppose. I just want to set up one thing, which is to clarify how we use the categorical approach under our side of the house. I think government was perhaps a little bit uncharitable in this sense, but what we think the way you approach categorical based systems is that we always select categories that are the most fitting to your particular bundle of symptoms. That is to say that if there is a more specific category that more specifically encompasses the symptoms that you have, we're going to pick that one. So accuracy isn't an issue in most cases. if when that diagnosis is being made. But also, I think it's also plausible to have multiple diagnoses with very overlapping symptoms, for instance, they can treat simultaneously in very similar manner to governments at the house. I don't think it's true that the diagnoses are often limited to one. It can be multiple depending on the particular symptoms of that person. So with that, I want to move on to my case. But first, I want to frame something very important, and that's to frame what really mental health treatment is for. I think the assertion that mental health treatment is supposed to solve mental health issues directly is perhaps a little bit too enthusiastic. I think there are two particular reasons to believe why this might not be the case. Because one, that mental health illnesses or symptoms and issues are incredibly complex, interconnected, and very difficult to actually solve properly, considering the causes are often incredibly complex, and that the treatment for those things is non-obvious given that we have a very limited understanding of how the brain works. But so secondly, that the professionals that treat these kinds of things often are incredibly busy individuals, very specialized individuals with a lot of clients and people to tend to, that simply do not have the time or the energy on capacity to be able to fully devote their time onto one person and to solve them fully, even if we had the means to do so. So what do professionals really do in status quo? I think their job is to simply prevent this person from being worse and to prevent them from doing the worst to themselves, to prevent these symptoms from tipping over and causing them to lose their life or something similar, to prevent them from harming themselves, for instance. It's not about solving them, it's to give them the space in order to fix themselves and to identify what might be wrong with them. This is the true role of a therapist or a doctor or things like that. Not to solve your issues for you, but to give you the space and the capacity to do that yourself. Because truly the only person that knows yourself is you, especially in the context of mental health. So then why are we more capable of achieving that kind of impact under our side of the house? There's two metrics I want to talk about. First, in terms of the biochemical aspect of mental health, and this will relate to medicine. And then secondly, I want to talk about the psychological aspect, how this relates to therapy and labels. First, on the biochemical aspect. First thing I want to frame here is that I think this debate is more impactful if we apply to individuals who have genuine mental health issues, right? We're not talking about individuals that are depressed after they got a breakup or depressed because they got a bad academic grade that one time. We're talking about people who genuinely have some sort of defect or some sort of problem with the way their brain works that constantly handicaps them psychologically speaking and prevents them from being the best version of themselves. Note that these kinds of illnesses manifest in biochemical disorders within the brain that need to be corrected if there's any long-lasting change were to happen. This is important, I think, because this outframes a decent chunk of OG's analysis. Because if you don't solve these root biochemical issues that appear within the brain, the very thing that medicine was created to do, then it's very unlikely you have any sort of long-lasting change, or at least it would be much more ineffective compared to actually getting that treatment. So what are the metrics that make this kind of treatment successful? I think it's in terms of identification of those causes so that you're able to mitigate and to actually help out in other aspects for that person as well. And the thing is that symptoms do not emerge by themselves. They emerge as a bundle from different kinds of causes all at once. When somebody presents with schizophrenia, for instance, the only symptom isn't just hallucinations. It's a host of other symptoms like emotional instability and things like that as well. What OG would do is to identify these symptoms individually and treat them individually. Whereas under our side of the house, we recognize that this bundle of symptoms is categorized as schizophrenia and that this is probably the most likely manifestation of this person's mental illness. I think in terms of identification, we're already more accurate considering the nature of mental illness as a whole. Secondly, in terms of selecting treatment, I think we're more clear on what kind of treatment to try for specific kind of bundles. Sure, OG is able to say that they have specific treatment for specific symptoms, but we have on our side is a long list of treatments that have been based on previous experiences of therapists, doctors, and the data collected for that specific bundle of systems that can treat all of them at the same time because they attack the root cause. And further, on maintaining treatment, I think paradoxically we have less medication under our side of the house because you're only treating one disorder instead of the multitude of symptoms that appear under OG. If anything, they have more medication, which makes it harder for people to maintain their treatment, which obviously negatively affects the treatment outcomes for these kinds of individuals. And that's what I want to say. It's not like we're going to be right every single time, but even when we're wrong, we put less of a burden onto these individuals to constantly try out and go through the symptoms systematically without any sort of guarantee that that might actually work. It's simply a more efficient system, medically speaking. But the second, in terms of therapy, first, psychological aspect. Firstly is on therapy. I think the way that therapy works currently is that you have to be attentive as a therapist because you want to collect as much information as possible so you can make the most accurate judgment on the category of these individuals. And I think this is something that is heavily emphasized because you have to make the most accurate diagnosis and the most accurate category. In fact, if you are forced to bundle people into just one category, that actually incentivizes you to be more accurate and more in-depth with your analysis and questioning of this person. Whereas under OG side of the house, when you focus only on symptoms, once you get one symptom, you have the confirmation bias that that is going to be the main symptom that you are going to treat without necessarily diving more in depth about why those symptoms arise, when they arise, why that happened, and how that feels for that person, simply because you're not trying to find the root cause. You're trying to fix the symptoms that appear out of that person. And the secondly is in terms of labels. I think there's actually closure for patients to help cope with themselves, given that they've lived their entire lives thinking that there's something horribly wrong with them, but never got that kind of validation. Giving a label that says it's not your fault, but it's literally just your brain biochemistry going against you is incredibly validating for these kinds of individuals, because it takes away the guilt that they often have from making these mistakes in the past life due to the illness that they might have. But B, I think it actually helps people take mental health issues seriously, insofar that you're able to assign a medical label to these things and show them that, hey, this is not something you should laugh at because it's genuinely something wrong with them. The same way that somebody might have a broken leg or might have a broken nose, for instance, that's something you have to take seriously. And that's why people even take mental health issues seriously at all, because they understand that it's a genuine clinical symptom that's not the fault of these individuals. And I think on all accounts, on terms of medication and in terms of the effectivity of therapy and the closure that these individuals get, which is the prerequisite to any kind of growth, that's why you oppose.
Then the leader of opposition for the speech to continue the case of opening government, call upon DPM. Here.
Hello, am I audible?
Yep, you're audible.
Right. Hold on, let me mute.
Oh, also wait.
Right. Should there be any POI, please just like let me know through chat. Please let me know like suddenly my voice is gone as well. But in the meantime, I'm going to start my speech in 3, 2, 1. My biggest criticism towards opening opposition's case is basically they don't know how mental health treatment in the status quo looks like. This will be my biggest contribution and my biggest rebuttal towards their case. Second of all, I just want to flag to you that all of this efficiency that they want to win upon is an illusion of efficiency, because at the status quo, all of this procedure that they want is basically no means of efficient mental health treatment. Third of all, when they try to dismiss all of the cases like being depressed after breaking up or being depressed after like getting bad grades, I think that this is one proof that they're very cherry picky, because in the status quo, exactly, mental health is becoming derogatory. People are using terms like being depressed after breakup, even though they're not depressed, maybe they're just overthinking it. This is exactly what the contribution of perception of Danesh is very important. That is exactly why they don't solve anything. First thing first, let's move to how does mental health approach looks like in the status quo. There are 3 characteristics. First thing first, using categorical approach in the status quo takes a lot of time. You need 10 times to therapy, for example, 10 times therapy session in order for the psychologist to understand which kind of disorder that you have. Because in order for you to be diagnosed as schizophrenic or depressed, for example, there's certain patterns that needs to be seen, only can be seen or visible after 10 times going to this session. Second of all, this is emotionally exhausting, because all of those 10 times therapy session, you're going to be in a 2-hour session only asking about how you are feeling, how you feel. You are going to be digging towards your trauma that makes you crying uncontrollably, and all of this very emotional, exhausting stuff. Third of all, this is very money consuming, because at the end of the day, all of this therapy session might not only be 10 times with the same therapist, but it can go from one therapist towards the other, which eventually you need to find the right therapist for you, the right psychologist for you, in order for you to be correctly categorized. This is the status quo that happens, that they dismiss. This implies that there are 2 things that happens in their side of the house. First, there are time, there are money that are being trade off in their side of the house, because at the end of the day, all of this capital are being consumed for you to just get this one category solved, or basically for you to get this one category labeled of your mental health issue. I'll tell you why this is really bad, because eventually all of this therapy session takes a lot of time while you still have work, while you still have time, while you still have study, while you still have exams, for example. All of this therapy session that just tries to dig what category are you takes up so much capital that it's very hard for you to integrate back towards your real real life. Second of all, this emotionally exhausting process is a very, very expensive currency. Why is that? Because along those process of trying to dig what category are you, you're going to feel like a failure, that you feel like your disease is unsolvable. Because why does the therapist doesn't know what I'm going through? Am I that dysfunctional and whatsoever? I'm just trying to tell you here that all of this basically prove to you realistically this is not an efficient process. What happens to them is they dismiss all of the capital that is needed, not only in terms of money, not only in terms of time, but also in terms of emotional capacity that every human have that is limited. So what I'm trying to tell you here, when they want to win over efficiency, there is no such thing as efficiency, especially when you all of these category are very complex category, very big names, very big disease that people needs to dig through in order for them to get the final verdict. Anyway, POI, yeah, sure.
Do you agree that problems in urination might lead to kidney problem?
Yeah, I wonder why that's correlated. But right, that's my contribution. That's my rebuttal. Let's move to the argument itself. My argument will be on in regards towards the perception of how mental health is going to be perceived in our side and why is it going to be better in our side of the house. I'll tell you right now that the main driver for development in psychology in status quo is to aim to see for diseases. Most psychiatrists focus in the treatment of ADHD, OCD, depression, and all of these big names or labels, for example. They focus on pharmaceutical approaches, i.e. they search for medicine, they search for better surgical treatment or whatsoever that is more lenient towards these big names. All of the small symptoms or pattern that we see in status quo are remain derogatory or even seen as like quote unquote pop term, i.e. when you have avoidance attachment issue, for example, that avoidant attachment issue, for example, it's really big on TikTok. People are starting to self-diagnose themselves. Second of all, when you're moody, this is something that is normal. Or when you're having anxiety or like overthinking, for example, all of these symptoms or all of these patterns are seen as normal, derogatory, or like pop terms in the status quo. All of this is very problematic under three reasons. First thing first, because of the pop terms of this pattern that is happening in the status quo, people are reluctant to reach out to psychologists, for example, because simply they think that this is a normal issue. Everyone goes through overthinking at some point of their life. Everyone goes through anxiety at some point of their life. So they cannot draw a line whether or not what they're going through is something that is normal or this is already a disorder, simply because they're already reluctant to reach out. This implies towards the dysfunctionality of themselves until eventually it becomes bigger and bigger. Suddenly it develops into something bigger, from anxiety into anxiety disorder, just because they dismiss all of their feeling because they think that this is normal. Second harmful implication is that people are reluctant towards going to psychiatrists because they know that when they go to psychiatrists, they're going to be labeled and judged, and people are going to resorting towards labeling them OCD or ADHD, for example, because this is what the treatment or the practice looks like in the status quo. People are scared to, are scared to be labeled ADHD in the status quo because there are so many mental health issue stigma, and we think that this is enough for them to give a reluctance towards going to psychiatrists. Third of all, this is literally the main driver of the self-diagnosing issue. People say that people have ADHD. A lot of TikToks currently basically making a lot of short videos in regards towards signs and symptoms of ADHD. This is going to be worse off when you are trying to neglect all of these patterns, all of these symptoms that are small. So the comparative, why is it better in our side? In our side, we are going to be focusing on these symptoms and pattern, and we're going to focus on treating them better. First thing first, we're going to say that, hey, anxiety is not something that is normal if you feel it over and over again, so that there's more specialization in regards to, what kind of practice that you can do in order to prevent them to be bigger. Second of all, this will no longer be a pop or derogatory term in our side of the house when the psychiatrists actually focus in reaching out towards people and educating. All of this is very important given the status quo of how mental health issue is preserved and how mental health issue is seen. With all of that being said, we solve the main issue, we win.
And the Deputy Prime Minister for that speech to continue the case of opening opposition and to close the interaction opening half, call upon the auto. Here.
Hello, am I audible?
Yep, audible.
Okay. Yeah, wait a second. Because I need to prepare my paper and also POI, please just through. Listen, wait a second. BPD and extreme anxiety might have the similar symptoms, but you will not administer the same thing because they'll have different holistic of issue. What does this mean? You can administer an anxiety meds to BPD individuals, but not BPD meds to anxiety individual because they do not suffer the same way the BPD people suffer of a mood swing. What does this mean to you? What they need is a representative of what they feel and what the disease is. Therefore, the treatment is needed to be accurate, not only based on like independent symptoms. This is why I will explain my speech in three categorical things. One, I'll explain why government comparative is inherently bad in terms of they want to create accessible math and such. But second, I'll explain on why labels are important. Lastly, I'll expand on clinic trials and advancement. First, I'll talk about OG. This is also engagement. What you want to say is that it's going to be important to create much more independent analysis on symptoms and also administer medicine through them. This is also make sure that accessible exists. What is the problem that comes to this? If a person have 6 different symptoms, it means they will need 6 different medication that will impose to them. It means more capital that are imposing to them that it will make sure they need to go back every week to get the same medication. But second, it also has the risk of dangerous overdose problem. That means that it's inherent harm for individual to take all these medication at the same time without acknowledging on how these biochemicals work in their brain. This is why my LO's contribution matter. In so far that biochemical is something that needs to be mitigated efficiently, that you will need to consider other symptoms that might be arising of this. In so far that they cannot understand or explain what is going to be better on their side, they cannot win this debate. But lastly, it's also traumatizing to make you go to therapy just to get medicine. This is different in our side. In so far, we'll get sufficient amount of medicine, just the right phase that you can mitigate your symptoms, right? On their side, they'll probably be dependent to it as much that's going to be traumatizing because consuming medicine is not easy, Judge. It makes sure that you can have a sense that you will lose yourself because the medicine are going to be controlling your mind. This is why an important balancing is going to be required in order for you to can mitigate the symptoms eventually. This is a flip because they cannot prove why all those medicines that are cheaper are going to be helpful to them or why people that consume this much medicine is going to be better. This is why what we champion on the OO is simply on why the benefit of having a holistic symptom is going to be efficient. In so far that this creates better access and much more accurate treatment. This is why it's okay if people having much more session with the therapist, because at least it means that they're being heard, that they can feel being, that is also a part of their coping mechanism anyway. This is what's important for these individuals to feel, to be validated, and this is an okay way even if they take money. Because no one is consented to have to go to therapist anyway. This is because of their needs in the end of the day. But second thing that I'll explain is regard of labels. Label is not a problem. People are labeling themselves, especially if they're like gay or bisexual or such. It's already a thing, right? So I don't get why adding one thing of their anxiety or ADHD is going to be a problem. Why does this thing in particular? Because each person needs an incentive to actually move on and be better, right? These labels give confirmation that something is wrong with them, and this makes sure that they know what to go with themselves. Well, these person have capacity, but they don't necessarily know how to use it. If they know what's the holistic issue, then they can find a new person that relates to them. This is existing and internet community that exists. There's no such thing of misdiagnosis, because if they misdiagnose themselves, they probably will still go to therapist anyway because they need to confirm it, because they have the anxiety over time, right? This is why it's going to be still important and not a harm understand if people have like labels. This is why they need a particular space to themselves. This is why it's going to be so much important to create a space for the patient itself, because this is what the job of being therapist does. It means that it's going to be much more productive insofar that people are going to be progressive, but also supporting individuals can be known. It's also make sure that people can relate, understand, and understand these people, tolerate these people better, because now they can easily know what happened with these people, as in people already know how it goes in the general approach. This is why it's going to be okay. But lastly that I'm going to talk about is about like advancement. The biggest contributor on how treatment can exist is how you can mitigate the symptoms, especially through your brain chemicals, right? It's directly how to manage to balance the chemicals, that because like people that are forgetful are not just cannot just be solved it just by simple medication or simple exercise or memory exercise, because exactly they can be suffering of Alzheimer. This is why that has not been any medicine for it yet. What does this mean to you, Judge? It needs a holistic issue, not something independent. Insofar that being forgetful might be a part of a bigger picture. What does this mean? It incentivizes people to research on a deeper level, not just a simple drug that creates better or treatment that creates one independent uh, yeah, in one way. This is because it needs to effectively approach on every way. This is why it will simply make sure that people that researcher can do this to make sure that there will be new medication to such thing, there will be much more effective treatment. This is why it's going to be so much important. But let's way over every bench insofar in OO. What we did as OO is the exclusive contribution on to explain how psychology in your brain works, on how people perceive things. This explanation is important and the prerequisite arguably really the most important insofar these answers on how people work on themselves and what the psychiatrists work. This is the much more important relationship that is need to be answered in this debate. If CEO want to take this, they're welcome, but we will still be the prerequisite to them because we explain how people perceive themselves or how we can do the treatment in particular. Proud to negate on opening.
Turn the deputy leader of opposition for a speech that marks the end of opening half. To start the exchange on closing half, call upon member of government. Here.
Tas, am I audible?
Yep.
Okay. POI, unmute. I'll take one prioritizing from opening. Yeah, I'll take one at 5. I'm gonna start my speech in 3, 2, 1. The first thing I want to establish is on who does this motion most likely apply to when we are talking about approach A and approach B. I think when the motion wording is approach, I feel like most likely there is a lot of discussion. But I don't think this discussion is catering to the normal people, but usually most likely catering towards the doctors, researcher, or the psychologist on deciding what kind of approach and research they want to have in like deciding and in researching on certain kind of symptoms or mental health, for example. I don't think normal people can control or contribute to the discussion as much. That's why when we are talking about the widespread use, most likely this apply to the context of the research debate on how like people are able to do like research in like academia, for example, which approach is the best, for example. I think this angle is probably going to have the most impact when talking about approaches we can take on treating mental health, because the more research that they find, the more info that we have, the more we can increase the capacity that doctors or therapists have to treat certain problems in status quo. The opening debate was only talking about how doctors should treat patients and what is the best way to approach if the issue is like mental health. Our angle is going to say this widespread means that the angle of research is going to be different, and therefore we're going to have more info on certain angle rather than the other angle. I think this is the most important delta here in the debate, because the angle of research leads to a lot more people asking questions questions, and therefore are able to find more answers, and therefore are able to help and fix the problem in status quo. So what is the comparative in a debate in Gov and Op, and why then this research is probably the most important part of the debate? I think the angle of research, most likely in government, this looks like how are we able to deal with specific certain symptoms when they show up? This looks like if you overthink a lot, we're gonna question are we able to stop those overthinking? How are we gonna strategize and stop mitigate that problem? Do you self-talk? Do you journal? Do you meditate? Or for example, if all of these are viable options, we're gonna analyze on which one is the most suitable to different kind of people. Or simply this looks like if you have anger issue, we're gonna talk about how certain anger issue could manifest. Is it nurture, or is it simply your personality? Is it because of your environment? Is it because of your trauma response, for example? And we're gonna try to find out on how are the strategy that you can have to deal with this anger issue, or even things like a lot of mental health issue. For example, if you cut yourself to get temporary relief, and if you, for example, do some kind of self-harm, the question, this is a very complex situation, right? Do you force them to stop even if they really want the temporary relief? Do you want them to, for example, just have temporary relief, for example, and let it get worse, and maybe it's lesser evil than other angle, for example? All of this are questions that is valid and needs more research. That's why the angle should be talking about this, because there is a lot of questions that we need to answer to get the solution that we want, to get the sufficient information that we want to decide on which is the most effective answer if we want to deal with certain mental health issue. How does opposition look like when you are focusing on resource when you allocate your research onto deciding if someone is on categorizing them? This looks like the debate, instead of focusing on what method is the best method to have, or what method is the most sufficient method depending on your age, on your gender, or all of those variables. Most of the time in opposition, the research is always about, is symptom A a valid symptom if we want to categorize it as depression type A or type B, for example? Or the debate can be about, is it valid to include a new symptoms when we're talking about anxiety? Or for example, if a new anxiety and a new variant of anxiety comes on, the discussion will be about if, for example, after a few years, if this certain still maintain its value, and is it still valid? Is the debate and research most likely is going to engage on previous research about how they are able to get the data, and are they valid or not? Or should we stop should we stop, or for example continue this kind of symptoms? This is the difference between Gov and Op on the research angle. We cannot really research on every single thing. In government, we're going to talk about the more of the solution, problem identification stuff. In opposition, they most likely would have probably compromising on solution. I'm not going to say they do not have any solution at all, but compromising on solution and focusing on their resource on deciding which method is which people have the right depression, or what type of depression do they have. I think it's much more preferable if we have all the solution and all the if we're targeting this research to the solution. Why then this is the most important case? But before that, opening, do you have any?
Wouldn't it be harder to find research subjects insofar that people never just present with one symptom but multiple symptoms at the same time that you have to identify?
I feel like in both sides it's gonna be hard. Yeah, I feel like in both sides it's gonna be hard anyway. In your side, it's super gonna be hard because deciding a symptoms also can require like years or months, at best months, for them to see it as a valid research. So in both sides it's gonna be hard anyway. So why then this is a very important case? This is probably, okay, number one, this frames out government and opposition's case about mental health stigma. I don't think it really matters, because most of the time, the widespread views is only directed towards research and, info, not towards the people's perception. This widespread is directed towards research and not people. So about that stigma, I don't think it really holds up in this debate. But this is also the prerequisite for on OG's case, because OG wants therapists to treat patients with this approach, right? But we say the prerequisite for therapists to successfully treat them is when there is already good info. to have the DSM, for example, cover the issue that they want to talk about. That can only happen, that can only be effective if you have enough research and enough info to go on. We say when you have a lot of solution, the research about a solution and problem identification, therapists are able to do this much better. In OO, they talk about, they talk about they wanting to let people fix themselves, and this is how therapy works. I do agree that's how therapy works, but it's actually much better when the research and the info that we give you is not only about identifying, but also about the solution and how to fix those solutions. Because at both sides of the house, most likely they're gonna deal with that issue anyway. Obviously, therapist is not gonna be the one treating them. Therapist is not gonna solve the problem. They have to solve the problem themselves. But at least in our side, the information that we give to you are on problem and identification and solving the problem. It's more proximate. It's more likely to be more effective rather than just identification. Most likely, if we're talking about solving the problem, we're actually much better on giving the info to the therapist, and therefore this is why research is probably the prerequisite for every single argument in this debate. Proud to propose.
I thank the member of government for that speech. To extent of opening opposition and also start the case of closing opposition, call upon member of Altruir here.
Am I audible?
Yep.
Just a general reminder and trigger warning in advance. I'm going to talk about a lot of mental health related substantives. So just general reminder, POIs, you can do it through the chat or raise hand. Please don't do any unmuting over or verbal. Don't do that, please. Yep. I think the other three benches in this debate directly jumped into why it's important to have or not have these things. But unfortunately, what is very important in terms of talking about mental health and the development of it and being able to treat it is making sure that there is a process and there is step-by-step analysis to make sure that every single thing works out perfectly and you're able to give out the proper diagnosis, right? This is exactly why closing opposition, we're going to fully mechanize to you what's been missing from the three other benches, because it seems like nobody here in this room is able to mechanize why certain aspects become very important as a prerequisite or something that becomes very important to impact certain things. I'm going to talk about two grounds, right? Number one, I'm going to talk about the professional conduct of mental health improvement. Two things to discuss here. One, I just want to talk about why initial diagnosis of mental illness becomes something that is very important. In any sort of treatment, DSM and ICD is used to identify the initial diagnosis and problem of mental health illnesses. The thing is that identification is a prerequisite to any sort of treatment because you have to start somewhere and still investigate what processes you have to pursue to heal the disorder. So, if someone feels like, or if someone seems like they're suffering from depression, but there is something unique about them because it's not entirely only depression, but it also seems to have things related to anxiety, then you start navigating in between the two grounds that you have already within specifically the manuals, right? But the problem in team government, both sides of the house, is that there will be an extended, prolonged process. Why? If you do use transdiagnostic like mechanisms, you will have to deep dive into like every specific, very niche things that you want to research on. For example, you need to do many interviews, ask them niche questions, ask them to recall the experiences that make them feel traumatized. You do not get the direct problems, that's one, but two, you do not know what to ask because there's no guideline. You don't know what to do when there are these kinds of issues, and therefore there is no processes of initial screening for you to navigate yourself upon because you generally just want to jump on the fact that they're probably like easily distracted, so perhaps they have some issues with them. What are the initial questions? That is the burden that both governments have never really answered. What are the grounds? But number two, I want to talk about on the idea of professional conduct as well, is the idea of research and development, especially prolonged R&Ds of DSM and ICD. This is going to directly engage to closing government. I think we're going to also break the deadlock of why complicated diagnosis that opening seems to throw around will also be catered to. The question that you have to answer, panels, first and foremost, when we talk about R&D, is that why do people engage in R&D? R&D is easy and interesting because there is a general identification of the phenomenon. In research ethics, problem identification only exists, and you want to research on something because you find that there are unique cases in society that is not stated specifically within manuals or guidances, or that doesn't have the research or publications yet. This is why a lot of the times they want to do research, right? It's not only based on the fact that like there are new things in the world, but you really question why are these things really not talked about previously. So you want to talk about something that is out of order and newly arising. The only way for you to measure this is when there's a priorly existing document for you to understand. And this can only be relevant when you champion the manuals and use them frequently. Both in OG and CG, you will constantly be stuck in trying to characterize abstract grounds of diseases. Like you try to like put your hands into the things, but you cannot seem to find why this person seems to suffer from these illnesses because you totally dismiss the manuals that are able to give you a lot of the grounds, even when there are things that are unfamiliar to you. So what happens then, right? This is therefore like going to be bad, right? Because you cannot have the grounds of pursuing research at the end of the day. But second, Len, even if not, I think both of them will stay simplistic. They water down the complexity of these illnesses and issues. So how does this help in closing opposition? We're the first to mechanize this in comparison to one. I think there are inclusion of new forms of disorders within the guidelines, which means that there are more actionable steps to understand new types of diseases. So if there are like more frequent cases of like hybrid diseases that people can encounter or feel, you probably want to, for example, create mechanisms in which can cater to both diseases. That can only happen when you feel like the current manual is not working and you want to innovate. The parallel example is like undang-undang. So in any type of act, you want to change it because it's not working and it's not catering effectively, right? This is the prerequisite that opening opposition forgets to explain. Like there needs to be this contextualization to understand why people become motivated. But two, what happens here is also there are new forms of treatment that is disclosed as a result of the R&D, like where it is going to be massively socialized to the psychological associations and mental health facilities specifically. And there's an actionable step out of this. Why is this contribution important? Two reasons. One, mental illness is time sensitive. Just like any other illnesses, this needs immediate actionable steps. But the way that you discover the complexity and try to act upon it is only when in closing opposition you understand that there are manuals that you have to follow, but because in the manual it doesn't exist, you want to research more and you want to help people in this context. This is why it's going to be long term. But number two, DSM and ICD becomes a prerequisite to cater to complicated and multifaceted illnesses in the future. Like CO is oriented to the fact that we want to secure the long-term benefits and specifically make sure that people are able to, have the grounds for research in this context as well. But secondly, I want to talk about patients a little bit, right? Opening opposition tries to talk about this, but unfortunately it's not crystallized well. I think the beauty of closure when it comes to illnesses and diagnosis is the fact that mental illness is specifically scary to experience. You're bothered on a day-to-day basis. You're afraid that your mind's or your brain's function will be altered. You don't want to lose yourself. You don't want to hurt other people or yourself, right? But what happens when there are guidance or guidelines is that with actual guidance and mapped out symptoms that exist within the manuals, you tell patients what are the specific characteristics, which comes with the identification of actionable steps, comes with the fact that you tell them specifically that these are the types of things that you might experience and that is something that is completely okay. We don't care about what society thinks. We care about what doctors think because these are the people who have the most credentials. What are the outcomes? One, they are more calm and reserved in approaching future recovery steps. So if they have to pursue any other mechanisms, they understand what becomes the problem. But two, they have more incentive to research and understand the illnesses that they have. Like as simple as reading what their doctors have already given them, resources on the internet, whatsoever. How do we win against opening opposition in this contribution? One, OO is just a premise. We tell you the context and the solution to it. But two, we also tell you why it's timely and very much needed to be solved because it's very scary. People have to get the closure as soon as possible. We win in this case. Proud.
The member of opposition for that speech to finish the case of government benches of all, to close the case of CG, follow upon government victory here.
Hello, am I audible?
Yep.
All right. For VI preference, you can just unmute your mic. Yeah. So I will start my speech in 3, 2, 1. Why is our extension important? My member already explained to you why is that transdiagnostic approach is better to be done nowadays in mental health treatments because how it's very dynamic and the process is not easy, like for the doctors to diagnose you. Where OG also kind of already explained about this, how it takes months, even years. That is why it's better in CG, because in our side, doctors can do more research because of the widespread, right? I will tell you more about the general people condition now towards mental health. First, people are now more exposed to mental health due to like contents from social media, and like there's the rising of like the mental health content, right? And second, public discourses about mental health is way more common now, where now people is and also it impacting on how people is now more accepting when you are mentally struggling, where they also make sure you are comfortable, right? With that characteristic, it's good to approach people with transdiagnostic, because the widespread that we are applying as CG here is that to the experts, which are the doctors, the researcher, and the psychologists, right? Because if we now do the categorical approach with the characteristic of the general people that I already explained to you, misinformation can happen more, and people tend to misdiagnose themselves. This kind of problems can occur more, right? Because like, for example, they will just do like, oh, I have tendency likes to clean up, then I have OCD, like things like that, right? So, and if I do this, it means I'm depressed. Things like that will happen. So OG case about my misdiagnosing can run under our analysis because we involve the experts, right? Now let's do the weighing also about with OG, where they explain that they want to solve like issues by one by one, like for example, the anger issue. They want to solve the minor problems first because of the umbrella diagnosis might happen, right? And this is what and also they want the categorical not become the common practice. And this is what differentiates OG and CG, because OG only explained to you about how it will then includes the people, the general people, because it takes a lot of time, right? But my member also already explained to you about how this debate is to supposedly include the normal people, because then my misdiagnosis happened, and also about this about and things I mentioned to you, right? So our extension is that now research will be more developed. So we want the research to focus to know how to process of like the mental health problems, and then how to mitigate it. We want it to be more nuanced. Well, in opposition side, you can it become categorizing, right? So in government side, it's problem solving, while in opposition side, it's only identifying. Because in opposition side, like the umbrella term will be applied to this, right? Because like you just do identification. You have to trade it off due to the limited resource on which one you have to focus on. In government, problem solving is much more important, because now people know what to do with themselves, right? And see, OG also explained about how people don't want to go to doctor. Yeah, I will take it later. They want to go to doctor because they think it's normal, and also how they don't want to be labeled, right? Well, we agree on that, and because of CG contribution, then these people later can be better treated because of the research that is already done. Right? Now let's moving on to CO, where they explain about how people are now confused because of no manuals, and people have no ground on pursuing research, right? But understand that CO mechanism is about how these manuals is good for the therapist to do to make the right decision, right? But in both sides of the house, therapists will use the manuals like DSM anyways, because that's the professional protocol they have to do, right? That's the difference is the content of the manual. Their CO mechanism and process analysis does not make a difference, as it is still the protocol. In our side, the content is about what solution is the best way to treat the symptoms that people are experiencing, right? And therefore, more capacity to treat these people. While in opposition side, they only stops at identification. We say on treating patients, we are better because we are trying to mitigate it, because we are trying to mitigate it from like the researches that's already done, right? And second thing, on CO's concern that we are gonna take a long time. But understand, we say that assessment is gonna take a long time anyways. Treating a depression takes months to years, and the way is that we say if the process is gonna be long anyway, it will be more fixable in our side. But yes, before 6, I will take your PI.
What specific kind of research happens on your side, and what's the comparative analysis that makes that better than research in status quo?
Yes, because now I think we already explained to you about this, about how the research will be more massive because because of the transdiagnostic will happen, right? And therefore people are now experts will do more of this research to treat the patients, not just on not on how to not on just the identifying it, but also the steps by steps on how to mitigate these symptoms, right? Now let's moving on to OO. They explain about how professionals want the symptom to be fixed, and yeah, and also they also want to do selective treatment because less medication, because medicine negatively impacts the people, and medicine put less burden. It will put less burden to the people on their side, right? And well, we agree that people should be given time by themselves, and that will manifest better in CG side. Because my member already tell you about how research will be done by doctor that treating the people and interacting with the people. They then do the research to know how to treat these problems. So more informations will be there, right? Because this is about how the doctor reacts to situation. So now doctor will then tell the patient how to treat themselves, and now patients have more guidance to treat themselves on daily basis, right? With that, proud to propose.
I thank the government whip for that speech. To close the debate as a whole, and we will also finish the case of opposition bench and CO, call upon opposition whip here.
Yeah. Wait, sir, setting up my timer. UI to regional chat to not unmute. Starting my speech and wait. Starting my speech in 3, 2, 1. I think I'm gonna bring two questions in this debate. First, whether general guidelines are needed in the mental health industry perspective, and second, which one provides better, outcome to the patients, in terms of in terms of the symptoms that they have or like issues that they have. Firstly, regarding the whether general guidelines are needed in the mental health industry perspective. Rizky actually already told you two layers of urgencies. But to summarize, categorical approach is important to help the mental health professionals taking care of the patient by giving them guidance on how symptoms initially lead to certain tendencies of mental health problems. This is the importance of initial assessment that is failed to be addressed and dismissed by the causing government and government bench, right? So a categorical approach is important for initial screening, and it's very urgent and important for professional to do it from general assessment to specific treatment because the mechanism in the status quo is that these professionals need to assess and help the patient quickly because this is a time sensitive issue like what Rizky have already laid out to you. This is why my POI to the deputy prime minister makes sense. General symptom needs to at least be classified first into certain categories in order for the professionals to find out what to do as first emergency aid before aiding more deeply over the time of the therapy or counseling, right? At least under our side of the house, we help the patient first because we know what to do when they talk to us about certain issues or certain symptoms, right? So how does this explanation weigh against a government bench? So firstly, against opening government, I think this closing opposition is better in explaining how the characterization of mental health issue, which needs a quick help and assessment. At least under our side, professionals able to deal with patients more easily because they know what to do even in the first counseling. For example, simply explaining that the patient may have tendency in certain mental health category before guiding the patient to, for example, they need to go to more specific professionals like clinical psychiatrists, behavioral psychologists, etc., right? In comparison to opening government and also closing government, closing government, transdiagnostic approach doesn't mean in the first meeting you will be able to find out what's the root cause. Root cause, like what Rizky have already told you, is far harder to be assessed because you need multiple session of assessment and interviews like my POI to the Prime Minister. You need to deep down in knowing patient's background before able to provide assistance for them, whether they need drugs or whether they need therapy. And it's very risky because you might lead on the patient to the wrong thing. But moreover, we agree to some extent to opening opposition. This means that you also need to solve every single issue under government bench. But closing opposition extends that initial baseline helps identification very easier in the case where mental health issue is very urgent and need emergency aid, right? I think we topple down government's bench argument on how it's better to assist the patient. At least under the professional perspective, we provide result in the first meeting to the patient. We don't have to necessarily conduct 10 sessions and solve each issue in order to provide first emergency. When we know that they have tendency to like ADD and ADHD, for example, we can tell them that this is your tendency as a first result. Probably you can try natural medication like ginkgo biloba, for example, for your ADD or ADHD, but we'll find out more in the next session. We can say that in the first session to the patient, right? While on your side, you cannot do that because you will not know that the anger issue have something to do with autistic spectrum, for example, because you refuse to categorize it, right? You refuse to learn from from the guidelines and the baselines that we have research on for centuries. So we're more relevant in in the context that this mental health issue is very time sensitive, and we mechanize the portrayal better on how professionals will be easier when dealing with patient, and patient at least satisfied with at least knowing the initial assessment in the first meeting, right? I think all of this explanation against government bench also topple down opening opposition's argument on urgencies, because opening opposition only talk about better access, because opening opposition can help identify one people into multiple diagnostic instead of being one-dimensional, yada yada yada. We think it's much more than that. Guidelines and guidance in the book, in the category from the categorical approach, is the best line in providing professionals and patients what to do at least the first time they realize the issue during the first counseling. Whatever happens, whether they need further counseling is a different issue, but that's the mechanism in the status quo that eventually you will have a series of counseling anyway, right? But let's the second layer in this clash regarding research and development. I think this directly clashes with causing government because CG never portray to you how the research differs. They suddenly claim it's gonna be better because they're not focused in deciding whether it's depression A or B. We think under our side of the house in CO, R&D is far easier if you take the approach from general to specific, meaning that research is you developing past general research into specific research by finding new novelty, new finding, new finding, and so on and so forth from what already exists in the status quo. This is R&D. You research on the meaning that under government, it's going to be very hard to do research because your kind of research is going to be very hyper specific on certain symptoms like anger issue or like social withdrawal, meaning it's going to be very hard to develop because you already focusing on specific person and individual. Best, your research going to be beneficial only for that certain individuals that you're assessing right now. But on our side, because we start on the general category, because we start on collecting data for making this general baseline, we don't focus on hyper specific individual symptom. We open up opportunity for novelty that could be beneficial not only for one individual, but for multiple individuals that have the same initial symptom or initial assessment in the future, right? This is why the contextualization argument and framing from Rizky's argument in the R&D is very important. General category provide the context for further research. That's why on paper, author told you that this research needs further research, right? So the way is that the gravity of mechanization and degree of benefit in R&D is far more achievable and larger under closing opposition in comparison to closing government, right? I think the problem of misdiagnosis are out of the debate because it really depends on the psychiatrist or psychologist, but at least we have a mitigation in which we gradually assess the patient based on the research that we have done centuries and in providing the initial assessment guided by the category, right? Let's move to the second clash. Which one provides better assistance to the patients? This is a messy debate in the opening. OG said the category makes people label themselves and it becomes derogatory and pop term. Meanwhile, OO said it makes patient being heard without mechanizing and putting importance on the significance. Firstly, I think the issue of whether labeling harmful or not is really a judgment call because it depends on the individual receiving the labeling, whether they're educated, whether they're woke and progressive, etc., right? But moreover, under government side, labeling also happen. Like you label people anger issue, you label people have social withdrawal, and if that person really want to self-diagnose, they're gonna self-diagnose. But I think what's important in the CO is the fact that we are working on guidelines and baselines under the category, meaning we have a series of information and a series of explanation based on our research and published category that the patients can refer. So probably if they try to self-diagnose and then they search on Google, oh yeah, I have these symptoms, oh probably it will lead to certain mental health issue based on the category of the DSM-5, then I have the needs and urgency to go to the therapy and so on and so forth. I think this is very clearly mechanized in the closing opposition that this category might lead people to label them, sure, that's symmetrical. But at least on the outside of the house, they know that it is something that's wrong with them, and they try to seek help, and they maximize all of the status quo in the psychiatrists and in the psychiatrists and psychologists, and also mental health industry in the that we have explained to you. Very proud to oppose.